Hello, I'm Dr. Nora Lane from the United States, and welcome to my channel. Today, we're discussing a question that shocks millions of Americans every year. Why does a simple 10-minute visit to the emergency room cost $5,000 or even more in the United States? For many people, the story starts the same way. You feel sudden chest discomfort, sharp abdominal pain, dizziness, or an injury that scares you. You don't have time to Google clinics or compare prices. You do what you're told your whole life to do in an emergency. You go to the ER, a nurse checks your blood pressure, a doctor speaks with you briefly, maybe a test or two is done, and within minutes or an hour, you're sent home. Medically, everything seems fine. Emotionally, you feel relieved. Financially, you have no idea what's coming. Weeks later, an envelope arrives, sometimes multiple envelopes. The total isn't a few $100s, it's thousands. And that's when confusion turns into fear. To understand why this happens, you have to understand what an emergency room really represents in the US healthcare system. And it's very different from what most people imagine. An emergency room is not just a room where doctors see patients. It is a high-intensity, high-cost medical command center that must be fully operational. 24 hours a day, 7 days a week, 365 days a year. Whether one patient walks in or 100, the ER must always be ready for heart attacks, strokes, car accidents, shootings, overdoses, and mass casualty events. That level of readiness requires highly trained staff, advanced machines, trauma bays, surgical backup, security, and specialists on call at all times. Even when you don't use most of these resources, their cost is still built into your visit. One of the biggest drivers of that cost is something most patients never hear about until they see it on a bill, the facility fee. This is a charge simply for accessing the emergency department itself. It covers the building, technology, emergency equipment, and the ability to treat life-threatening conditions at any moment. A facility fee alone can range from several hundred to several $1,000s, even if your medical issue turns out to be minor. In other words, you are paying not just for what happens to you, but for what could have happened. Another key factor is triage, which is the system errors used to decide who gets treated first. Many people believe that if they waited a long time, their condition must not have been serious. Medically, that might be true. Financially, it makes no difference. When you arrive, the ER must initially treat your symptoms as potentially life-threatening. Chest pain is treated as a possible heart attack until proven otherwise. Headaches can be brain bleeds. Shortness of breath can be a pulmonary embolism. This uncertainty justifies rapid evaluation, monitoring, and testing, all of which are expensive. Then, there's the issue of time versus value. In the United States, healthcare pricing is not based on how long a doctor spends with you. It's based on complex billing codes that reflect perceived risk, decision-making complexity, and liability. A 10-minute conversation that rules out a heart attack is considered high-value, high-risk medical decision-making, and it's billed accordingly. You're not paying for minutes. You're paying for expertise, responsibility, and risk. Another surprise for many patients is that emergency doctors often do not work directly for the hospital. They may be part of a separate physician group contracted to staff the ER. This means you can receive one bill from the hospital and another from the doctor, even though the visit felt like a single experience. To patients, it feels like double billing. To the system, it's standard practice. Now let's talk about testing, because this is where costs rise very quickly. Emergency medicine in the US operates in a highly litigious environment. Doctors are trained to rule out worst-case scenarios, not just identify the most likely cause. That means ordering blood tests, imaging scans, and monitoring that may later seem unnecessary, but at the time they were medically and legally justified. A single CT scan can add thousands of dollars to a bill, even if it comes back completely normal. Another critical reason air visits are so expensive is the pricing structure itself. Hospitals maintain what's known as a charge master, a list of prices that are often many times higher than the actual cost of providing care. These inflated prices exist so hospitals can negotiate with insurance companies. Insurance rarely pays the full amount, but the original charge still appears on the bill, creating shock and confusion For patients, if you are uninsured or out of network, those inflated prices matter even more. Emergency rooms are also legally required to treat everyone regardless of their ability to pay. This is a moral and legal cornerstone of us emergency medicine, but it comes with financial consequences. Hospitals absorb billions of dollars in unpaid ER care every year. To survive, they shift those losses onto paying patients through higher charges. In simple terms, the ER bill you receive often includes the hidden cost of someone else's unpaid care. So when people ask, why did my 10-minute ER visit cost $5,000? The real answer is this: you weren't paying for 10 minutes. You were paying for round-the-clock readiness, advanced infrastructure, legal risk, systemic inefficiency, and a healthcare model built around insurance negotiations rather than transparency. And this is only the foundation of the problem, because once insurance enters the picture, things become even more complicated. To really understand why emergency room visits become financially devastating, we now have to talk about the most confusing and misunderstood part of American healthcare, health insurance and medical billing. Because for many patients, the ER visit itself isn't what causes the damage. It's what happens after the visit, when insurance steps in or doesn't. Most Americans believe that having health insurance means they are protected from massive medical bills. In theory, that's true. In reality, emergency care is where insurance protection often breaks down. One of the biggest reasons is something called out-of-network care, and this is where thousands of dollars quietly appear on people's bills. Here's how it usually happens. You go to an emergency room that is listed as in-network under your insurance plan. You assume you're safe. But inside that ER, the doctor who treats you may not be employed by the hospital. The radiologist reading your CT scan, the anesthesiologist, or the lab processing your blood. Work may all be part of separate medical groups, and those groups may be out of network. You had no control over this. You didn't choose them. You probably never even met them. Yet their charges can legally end up on your bill. This is known as balance billing, where insurance pays only what it allows for out-of-network providers, and the remaining balance is billed directly to the patient. For years, this practice shocked Americans. Laws like the No Surprises Act were created to reduce it, but gaps still exist, especially with ambulance services, older claims, and complex emergency situations. Many people still receive surprise bills, despite doing everything right. Ambulances deserve special attention here. In many parts of the US, ambulance services are not covered as a network, even when the hospital is. You don't get to shop for an ambulance during an emergency. You don't negotiate prices. A short ride can cost anywhere from $800 to over $3,000, and that bill arrives separately from the hospital bill. For many families, the ambulance bill alone becomes a long-term financial burden. Then there's the issue of deductibles, copays, and co-insurance. Emergency room visits almost always trigger the highest cost-sharing levels in insurance plans. If you haven't met your deductible, which for many Americans is several $1,000s, you may be responsible for most or all of the ER bill yourself. Even after meeting the deductible, co-insurance can leave you paying 20 to 40% of a very large number. Another hidden driver of ER costs is medical coding. Every symptom, test, decision, and diagnosis in the emergency room is translated into billing codes. These codes determine how much the visit costs. The difference between a moderate complexity code and a high complexity code can be thousands of dollars. Patients rarely see these codes, and even fewer understand them. Yet, coding errors are extremely common, and they almost always favor higher charges, not lower ones. Hospitals and billing companies often code air visits at higher levels because emergency care is considered inherently risky, even if your condition turns out to be minor. The potential seriousness at the time of evaluation justifies higher level coding. From a medical perspective, this makes sense. From a patient's financial perspective, it feels deeply unfair. Another factor most people don't realize is that insurance companies don't pay what hospitals charge. They pay negotiated rates that are often far lower. Hospitals inflate their listed prices, sometimes by several 100%, so they can negotiate with insurers and still recover costs. When you see a $5,000 year bill, insurance may pay only $1,200 of it. The rest becomes a complicated financial tug-of-war between the hospital, the insurer, and you. For uninsured patients, this system is especially brutal. Without negotiated insurance rates, uninsured individuals are often billed the full charge master price. Some hospitals offer discounts or charity care, but many patients don't know to ask or are too overwhelmed to fight. Medical debt remains one of the leading causes of bankruptcy in the United States, and emergency room bills play a major role in that reality. There's also a growing influence that rarely gets discussed: private equity in emergency medicine. Many emergency physician groups are now owned by large investment firms. Their goal is efficiency and profitability, not necessarily patient affordability. These firms optimize billing strategies, aggressively pursue collections, and maximize reimbursement. The doctors you meet may care deeply, but the system behind them is increasingly driven by financial algorithms. Another problem is lack of price transparency. In almost every other service, you know the price before you buy. In emergency medicine, that's impossible. You can't ask for a menu of prices while experiencing chest pain or fear. The system evolved without consumer pressure because emergencies remove choice. And where choice disappears, prices tend to rise. Even basic items in the ear can feel absurdly expensive. A simple pain reliever, a saline 4, or a bandage can appear on a bill with shocking prices. These items aren't expensive on their own, but they are bundled into a system designed to recover overhead costs, administrative expenses, insurance negotiations, and legal risk. By the time all bills arrive, patients often receive multiple statements from different entities, each with its own due date, codes, and confusing language. Many people don't even know who to call first. Fear, shame, and stress take over. Some delay payment, some ignore bills entirely, and that's when collections, credit damage, and long-term financial consequences begin. So while the ER may have treated your medical emergency in minutes, the financial emergency can last for years. And the most painful part is this: most Americans are never taught how this system works until they are already trapped inside it. And that brings us to the most important part of this conversation: what you can actually do to protect yourself, reduce damage, and take control when an ER bill arrives. Now that you understand why emergency room visits are so expensive, and how insurance and billing systems amplify those costs, the most important question becomes this: what can you actually do about it? Because while no single person can fix the American healthcare system, there are very real steps that can protect you from financial harm, and most people are never taught them. The first and most powerful step is this: never accept a medical bill at face value. When you receive an ER bill, your first reaction might be fear or panic. That reaction is exactly what the system relies on. Hospitals expect many patients to pay without questioning, simply because the language is confusing and intimidating. But here's the truth: billing errors are extremely common, especially in emergency care. Duplicate charges, incorrect codes, and services you never received appear on bills every day. Always request an itemized bill, not a summary. An itemized bill lists every charge, test, medication, and service individually. Just asking for it often pauses collections and opens the door to review. Many patients see their total drop simply because errors are corrected once someone looks closely. Next, if you have insurance, carefully review your explanation of benefits, often called an EO. This document explains what your insurance paid and what it didn't. Insurance companies deny claims all the time, sometimes incorrectly. Appeals are not rare exceptions, they are a routine part of the system. Patients who appeal, especially in emergency cases, often succeed. The key is persistence. Another critical strategy is negotiation, and this surprises many people. Hospital bills are not as fixed as they appear. If you call the hospital billing department and explain your situation, especially if you are uninsured or facing hardship, discounts, financial assistance, or payment plans are often available. Many hospitals would rather receive a reduced payment than nothing at all. Asking costs nothing, but not asking can cost thousands. Understanding when to use the ER versus urgent care is another major protection tool. Emergency rooms are essential for life-threatening symptoms, chest pain, difficulty breathing, signs of stroke, severe trauma. But many conditions can be treated safely at urgent care centers for a fraction of the cost. Sprains, minor cuts, infections, and flu symptoms often don't require ER-level care. Knowing this difference ahead of time can save enormous amounts of money. It's also important to understand your insurance plan before an emergency happens. Know your deductible. Know your out-of-pocket maximum. Know whether urgent care is covered differently than ER visits. In a crisis, you won't have time to read your policy. Preparation is protection. For ambulance services, ask your insurer whether ground and air ambulances are covered and under what condition. Ambulance billing remains one of the most dangerous financial traps in American healthcare. Awareness doesn't eliminate the risk, but it reduces shock and allows faster action when bills arrive. If a bill becomes overwhelming, do not ignore it. Medical debt can be sent to collections and damage credit scores, making it harder to rent housing, buy a car, or even get a job. Early communication with hospitals and billing agencies matters. Silence is often interpreted as refusal, even when it's really fear. There is also growing help available. Patient advocacy services, nonprofit organizations, and medical billing advocates can review bills and negotiate on your behalf. Some charge fees, others don't. In high-dollar cases, their involvement can be life-changing. But beyond individual strategies, there is a deeper truth that needs to be said clearly. The high cost of emergency care in the United States is not primarily caused by doctors or nurses. The professionals you meet in the ER are often working under intense pressure, long hours, and emotional strain. They save lives every day. The problem lies in the structure surrounding them: insurance complexity, administrative overhead, legal risk, and profit-driven systems layered on top of care. Emergency rooms exist to protect life, not financial stability. Yet in America, the two are dangerously intertwined. A system designed to treat medical emergencies has become one of the leading sources of financial emergencies. This is not because emergencies are rare, but because pricing is opaque, insurance is fragmented, and patients are expected to navigate complexity during moments of vulnerability. That's why education matters. When people understand how our pricing works, fear loses power. Knowledge doesn't eliminate risk, but it gives you tools. It allows you to ask questions, challenge errors, and advocate for yourself or your family when it matters most. If there is one message to remember from this discussion, it's this: a short ER visit does not reflect a small cost because the system was never designed to charge by time or simplicity. It charges for readiness, uncertainty, and infrastructure, whether you use it fully or not. I'm Dr. Nora Lane from the United States, and this channel exists to help you understand healthcare clearly, honestly, and without intimidation. Emergency rooms save lives, but understanding how they are priced can help save your financial future. Thank you for watching, and welcome to the conversation that every American deserves to be part of.